Yeah, same here in Pune. Also, the numbers have come down drastically.
Yeah.
We have Dr. Krishna, I think, joining in. Good evening, Dr. Krishna.
Hi Mahesh, how are you?
Fine.
Hi Abdul.
Hi, Krishna.
Hi.
How are you?
Good. Which part of the world are you in? Are you home for Onam or what?
No, I'm in Chennai. Hi, Aksha. How are you?
Hi, Dr. Abdul Ghaffar. I'm good. How are you?
Okay, fine. Thanks for joining.
My pleasure.
Now it's 7 o'clock, yes.
No, we have about 8 minutes left. So.
Yeah.
Do we need to call people? We still have about 4 minutes.
I think Dr. Anand and Dr. Jacob is left. You have to unmute, Abdul.
Do we want to call them or do we have a number we'll call? Mahesh, will you tell them to send the SMS link now?
Sir, it's already sent, sir.
Good evening, Dr. Heyman.
How are you?
Good.
Good.
So it's
Thanks very
mid-afternoon. Just afternoon for you.
Yeah, it's mid-afternoon. Yeah, not so late as for you.
Right. No, I'm just finishing up with patients here, and
Hi, Pratyush. I just called Dr. Jacob John. Something wrong with his connection link, Zoom link. Can we send him the link again? Something wrong there?
Dr. Ghaffur, I've already sent him the link right now.
All right,
Thanks.
again.
I've
Okay,
resent
fine.
the link.
send it to his phone again, please.
Sure, sir. Yeah.
Just send it by WhatsApp. He can at least be interesting. I think Dr. Ban is also here.
Should we start waiting for Dr.
We'll start. Dr. John can join, right? Abdul.
Yeah.
Hi, good evening.
Hi everyone.
Hi, Anand.
Hi, Dr. Ban.
I joined a couple of minutes later.
Okay. So Mahesh, can I start off and you can close?
Okay, that's fine.
Okay. Good evening and welcome again to this very exciting edition of All Things COVID. I'm Dr. Krishna Shishadri. Dr. John is also joined.
I've joined.
Yes, and thank you. Let me. Let's start again. So, good evening, everyone, and welcome to this edition of All Things COVID. And we are joined by our very eminent panel that has been meeting almost once in 3 months through this entire pandemic to walk you through an iconoclastic set of discussions ranging from COVID, its variants, its impact on public health, on policy, on vaccinations, on strains. And we have expanded our team today that joins it. Has joined this team, and Dr. Ghafoor will introduce you in greater detail. And we have, as usual, been by Dr. Abdul Ghafoor, a consultant infectious disease specialist from Chennai, whose realm of expertise has deepened in these COVID years. Whether it is ethics, public health, or virology, or the clinical part, what we have in store is an exciting evening. Thank you for sharing. Just to sort of reiterate that GCCMC is a platform that has been created by the CSR. We have reached out to physicians through these webinars, through basic certificate courses, but we've also in the last few months spent a lot of time taking podcasts and creative visual creatives through social media, through newspapers to get people to get over vaccine hesitancy. And so hopefully one of the things that we will know about is has India done the right thing by not going with the Pfizer, especially with the Israel data that's just starting to emerge. So I'm actually planting a question. Abdul, it's all yours. The next 90 minutes to take us through this. Absolutely fabulous. We already have 63 people on this particular platform, and we will have more joining through the YouTube link. And this is wonderful over a weekday evening. Thank you so much, Abdul, all yours.
Good evening. Thanks, Krishna. Thank you, Dr. Jacob John, Dr. Aksha, Dr. Anand, and David. This is our third in the series of CMEs on COVID pandemic. We had our first CME in December last year. That is at the end of the first wave and before the beginning of our national vaccination campaign. And then we had a tsunami of the second wave in our country, and the size of that tsunami was unexpected and unpredicted. We had our second CME in April this year after the onset of the second wave. And then we had the size of the second wave really created a lot of trouble in our country. We were in a shock state at the beginning, but we recovered fast. We improved our logistics, and today the COVID is in a manageable state in our country with less than 40,000 cases a day. That itself, majority of the cases are in a few states. At a global level, rich countries have made excellent progress in the vaccination, but poor countries are lagging behind due to inequitable access in vaccination. Dr. David Heinemann, a very famous epidemiologist, is going to update us on the global scenario on the vaccination front. David?
Thank you very much, Abdul. Are you hearing me?
Yes.
Thank you. Good. Well, I just took a look a little bit ago at the Bloomberg Vaccine Tracker, which is keeping track of where vaccines are being distributed and where they're being used in the world. And actually, there are almost 5 billion doses of vaccine which have been used in the world to date. And in India, that breaks down to 561 million doses, enough for 20% of the population to be vaccinated 2 times. However, in India right now, what is being seen is 32% of people have one dose and 9% are fully vaccinated with 2 doses. India, in fact, is, as you know, 17.7% of the world's population. And if you do a calculation, you'll find that it presently has about 11.6 of all the vaccines in the world in use in India. So there's a long way to go in India, but there have been great strides made moving forward. Vaccines are really powerful, as we've seen in many countries, and they permit you really to make sure that those populations at greatest risk of serious illness after infection, including the elderly, those with comorbidities, and some others, making sure that they can be protected against serious illness, although they're not protected against infection, as we know. These vaccines were not measured against preventing infection. They were only measured to see if they could modify infection in humans. And we see that there's a great range in the breakthroughs that are occurring even with the initial virus that came into countries. With the Delta variant, however, we're seeing that there are many, many more breakthroughs of infection after the second dose of vaccination, but those breakthroughs are not causing serious illness. So we're seeing that the vaccines are still effective in preventing serious illness and death, but they're not as effective as we would hope in preventing initial infection or following on infections in people who have been vaccinated. There's been a real misunderstanding by epidemiological modelers and by the general public because of confusion in the press about herd immunity. Sorry, I was muted again. Herd immunity, which means interruption of transmission because there's enough solid immunity in populations, will never happen with the current vaccines for COVID infection. What we're seeing is that gradually population immunity is increasing either because of natural infection or because of vaccination. In countries where there's a high vaccination coverage, such as the UK, are seeing 9 out of 10 people who have antibody to infection. But we don't know what that antibody means. We know it correlates with some decrease in severity of illness, but we don't know what the T cells are contributing to that immunity. And so we don't yet understand correlates of immunity. But what we are seeing in countries like the UK and in many countries around the world where there's been a major epidemic of natural infection is that population immunity is developing. That will cause a herd immunity effect, and it will modify the epidemiology of infection, but it will certainly not stop transmission. This disease, this infection is with us to stay, at least in the near future. It will be endemic and continue with us. So Abdul, I hope I've been able in a short period of time to just give an introduction to vaccines and where we stand today with those.
Thanks, David, for the excellent introduction. And we will discuss more during the panel session. Dr. Jacob John, nobody could predict the size of the second wave in our country. But during our second CME, you predicted the second wave will be, and that CME was after the onset of the second wave, but still before the peak. And you predicted the second wave will have a very sharp ascent and a sharp descent. And that turned out to be perfect. Your prediction on the second wave pattern was perfect. What is your prediction on the third wave? Are we going to have a third wave? Is it going to be big, small? Is it going to be due to variant? Sir?
Thank you both for inviting me and for arranging this meeting. It's a great occasion to catch up. Am I audible? I hope I am audible.
Yes, sir.
Okay, so epidemiologists are the prophets of public health. And prediction is not a crystal ball prediction. Looking at multiple factors and putting them together and coming to a probable conclusion, a conclusion of probability. So anyway, I turned out to be right, and because my ingredients that I used were right. Can I have the, I'm titling this as Unlikelihood of a Third Wave in India. So it tells it all. Okay, that's a statement of prediction. Next slide. A wave is a fresh outbreak on the background of either endemic or an outbreak that is declining, and then a fresh outbreak. And when we say wave, we are talking about disease, not infection, which is a silent phenomenon until or unless disease occurs. The main determinants of an outbreak or a wave is a large enough pool of susceptible population. Larger the pool, greater the probability of a wave. The second determinant is the basic reproduction number R0. Larger the R0, greater the probability. Now, R0 is a property of a particular virus. It doesn't change. It's kind of it's a characteristic that remains with the virus. People mistake between R and R0. Anyway, I hope everyone knows what R0 is. If the susceptible pool is very large, R0 need not be very high for an outbreak. If the R0 is very high, the susceptible pool need not be very large. This is the basic background information. Next slide. Here is the picture of the two waves of India with a population of 1,400 million. You can see that these are artist-drawn like symmetrical waves. The first wave, its ascending limb and descending limb were quite reflex mirror image. Second wave, likewise, the ascending limb and the descending limb were mirror images. The first wave actually began in March of 2020 and ended by January 21. 11 months, 10 to 11 months it lasted. Then after a period of low level of daily infections, the second wave took off rapidly, as Abdul just now said, and it has now settled down to about 40,000 per day for the last 2 to 3 weeks. It's a steady state now. The daily infections are neither climbing or declining. So it's a fairly steady state. And the second wave lasted only 4 months, whereas the first wave lasted 11 months. So keep this in. The dates are, and today is the last date on this graph. And so July, mid-July to August is that flat, steady state. So keep that in mind. Next slide. This is the UK graph. You can see the first wave was quite short. It lasted about 4 months, less than 4 months. It was due to the D614G variant. I will come back to that a little later. The second and third wave, biphasic second wave or second and third wave were alpha beta viruses predominantly. And the fourth wave is Delta, by and large, Delta. And you look at the dates, the present wave in UK is fairly high when India has reached the steady state. So again, this graph is up to today. Next slide, please. Now, this is a complicated looking but very simple slide. Different people use different terminologies. They say variant is one terminology, lineage is another terminology, and clades are another terminology. So these are these colors show various clades. Let's look at India. The initial clade 20 series was the European variants introduced to India from western front of India, Middle East and Europe. That is a dark gray. Thereafter, there are two grays. The top was the 19 clade, which is the original Wuhan, and the one below, the 20A, is again part of the D614G variant. The top blue is the alpha variant, or clade, belongs to clade 20. Then the blue that has spread from top to bottom on the right hand side is the 21A clade, which is delta. In between, there is a light green one. It's called kappa, which is a mutant of the 21A clade, which came and it virtually disappeared. So since about end June to today, or not, actually this is up to 7th of August, 100% of Indian isolates genome analyzed by the Indian INSACOG, that group that keeps a watch on the variants, 100% delta. That is, the second wave, as it peaked and as it has come down, and the steady state are all delta. Now, the world picture is shown in the upper panel. Again, it starts with the grays, that is the 20 lineages, and then you can see the blue, the alpha, that was detected in September of 2020, and that expanded globally. The top blue is I forget what the top blue was. Anyway, so the middle blue is the alpha variant, which became quite widespread in the world. And as time went on, from about April, May, the delta variant has expanded. And as of 7th of August, 92% of global isolates, much larger number tested, are delta wave. In Latin America, there is the lambda, which is on a global scale, it is a very, very small proportion. Next slide. So the size of the India's susceptible pool, we can calculate looking at this, the distribution of delta and the height and spread of the two waves. Starting with 1,400 million people, the first wave with D614G with a conservative value of R0 of 1.5. People say it was 2 or little above 2, but I'm using 1.5. And there is a way of calculating the herd immunity level when that outbreak actually abates or withdraws. And approximately 400 million people were infected in that first wave lasting 11 to 12 months. There are other people have calculated 300 million. ICMR calculated about 300 million, but I think they are underestimates. So approximately 400 million is my estimation. The second wave with Delta variant, the R0 is anywhere between 6 and 9 according to calculation. You cannot be sure of the R0 in the middle of an epidemic because a lot of people are already immune. So you don't know exactly what R0 is, but the CDC has calculated it to be about 7, 8, or 9. I'm conservatively estimating it as 6, which means using the formula 1 minus 1 by R0 as the threshold of herd immunity when the outbreak recedes, about 75 to 80% of the 1,000 million have been infected. So 750 to 800 million. So balance left are 200, 250 million people widely distributed. That's not enough for a wave. Unless a new variant emerges with much higher R0, I don't expect a third wave as such. Next slide. Okay, this is the mortality, death. I just want you to focus on the third small current death rate, very low death rate. That is the effect of an effective vaccination program where those who are at risk of severe disease and death by and large have been well covered in UK. Next slide. Look at its parallel in India. This is death. The death in India during the second wave was not modified, reduced by vaccination. That is our missed opportunity. We had enough time to plan and roll out the vaccine and give it to people at risk of severe disease and death. If only we had done that, we would not have this kind of a graph. As of today, the second dose vaccine coverage is only about 8 or 9% in India. Next slide. So the reason why we worry about the third wave was because the science advisor to Prime Minister predicted a third wave in May of 2021. All India Institute of Medical Sciences director echoed the same in June. Professors in IIT, Indian Institute of Technology in Hyderabad and Kanpur, confirmed prediction with some mathematical modeling. What you put in will determine what comes out of a mathematical modeling. Pediatricians expected it predominantly in children because the second wave, there are a lot of children being affected. And if you really analyze it, the children getting affected was a proportionate phenomenon to the total infection. If in the first wave, 100 people were having disease, 5% were in children. In the second wave, if 1,000 people had the disease, 50 were in children. So the 5 and 50 actually were determined by the 101,000 total disease. The reason why we, next slide. So the third wave was predicted even before the second wave had peaked. We have a simple rule of 3 in India. Misfortunes come in 3. If second wave followed first, third has to follow second. That is the rule of 3. Coming from scientists doesn't speak very well of the scientific temper of the nation. A lot of energy has been spent by too many people on this prediction. Next slide. This is to show that the AIMS, the latest Zero survey by AIMS, shows that a lot of children have been infected, nearly 60%, and nearly 65% adults. You must remember that antibody surveys always underestimate the real community immunity. By a factor which is not very easily calculated, ICMR serosurveys showed that people with known past RT-PCR positive infection, only about 65 to 70% showed up as positive in the serosurveys. So these are underestimates. But the point I'm showing is that researchers say that anticipated third COVID wave may not affect children much. Okay, that's the point of this particular slide. Next slide. August 13, there was still announcement by senior experts saying that the second wave is still continuing. Now that is problematic because the second wave disappeared and we are in the steady state for the last 3 weeks. So people don't understand the steady state. The steady state is when the R is 1. That is, there is no outbreak. You must remember that we add 64,000 birth cohorts on a daily basis. So 64,000 new non-immune people are being added to the population. So we must expect a fairly large number of disease, at least until more people become immune. So the scene was one of fear and fascination by the scientists and fear by everybody else. The science in it was zero. I'll stop here. Thank you very much.
Thank you very much, sir. Now, Dr. Jacob John is the most reputed virologist in our country. He has just stated that our country will not have a third wave. And this statement deserves to be the headlines in tomorrow's newspapers and TV channels. And he has very well explained the scientific basis behind his prediction. I'm sure we will have a lot of discussion about this prediction in the panel discussion, and I'm sure later in other academic circles. Dr. Anand Ban, welcome. Several countries have introduced the vaccine passport. World Health Organization hasn't recommended vaccine passport. Indian government is against the vaccine passport concept. Even then, several states are demanding a vaccine certificate or a negative RT-PCR test for the interstate travel. How ethical is this vaccine passport?
Sure. Thanks, Abdul. A pleasure to be again on the panel. And, again, already we've had some really interesting inputs from both Professor Heyman and Professor John. So interesting question around vaccine passports. Now, if you look at this concept of a vaccine passport or an immunity passport, it's not necessarily new, but it's certainly gotten more currency during the current pandemic. And what essentially is a vaccine passport, right? It is some form of a documentary evidence that you show to prove that you have been vaccinated against a particular disease. In this case, it could be COVID-19. Now, how will you do it? You could have a paper-based certificate. You could have an app where it shows up that I have taken both doses of my vaccine. If it's a double dose vaccine or a single dose vaccine, then single dose of that vaccine. It could be authenticated. You can authenticate it by having a database, or you could have a QR code on it. So typically, that's what the kind of various kinds of vaccine passports we're seeing. Who's using it? There are some countries already who've started to use it. Japan has had some early mover advantages there. Israel has been using it. The EU member states have been using it. They've call it the digital green certificate. So it allows them for travel to happen within the member states within the EU. As you're rightly pointing out, in India, we've also seen this happen. Many airline companies or many states will allow you to travel. Say, if you're entering by air, even if you don't have a negative RT-PCR, as long as you can show that you've taken both doses of your vaccine, they will let you through. Otherwise, they might test you, or they might require you to quarantine, etc. So it's, of course, already gaining traction even in India. As you rightly said, WHO has not endorsed it. Now, what could this be useful for? I mean, certainly one advantage is that it incentivizes or nudges you towards vaccination, right? If you are someone who needs to travel frequently, you're a business person, or you have a requirement to travel for personal needs, and there is a requirement to have this kind of a certificate, then it will nudge you to get vaccinated, because without that, it will be difficult for you to travel, or you'll be required to quarantine or isolate or get tested at a high frequency, and hence you will decide, okay, it's easier for me to take the vaccine, even if I am reluctant. The second thing is, it could help in perhaps exposing those who might be vulnerable to those who might not yet have been vaccinated, could potentially be infected, and so puts those at risk, gives them some element of protection. Though it's important again to remember what Professor Hemant said in the beginning, that the evidence so far is more around protection from serious disease and lesser so around prevention of infection, right, or spread of infection. So the belief essentially is that by increasing the likelihood that people will get vaccinated, because there will be this push factor, it will help enhance an interest in getting vaccinated and enhance vaccination coverage as well. Now, your question was, what are the ethical issues? There are several ethical issues here. One is that it's not the case that vaccines are available to everyone who wants one, right? There is a shortage of vaccines. There is a global shortage of vaccines. There is also a national shortage of vaccines. And this is something that we are all well aware of. So to require people to have a demonstrated proof of getting vaccinated when they might not necessarily have access to vaccines and both doses of the vaccine for that matter, of course, is an issue, because if I'm not able to, even after trying a lot, then how can I come up with a certificate which shows that I have gotten the vaccine, because I've tried everything and I'm not able to access one. There is a certain element of surveillance as well here, because you're going to violate people's privacy by requiring them to have certificates. Though anyway, you are typically when you're traveling, you are required to demonstrate some element of identity. So I guess that is a lesser problem or lesser challenge. But of course, part of the problem also is there is no standardization of vaccine passports or certificates. So some countries will say, as long as your vaccine has been certified in some way by WHO, so their panels have looked through it and said, yes, this is an acceptable vaccine and we are happy with the data, then those countries might accept you having a certificate which endorses that you've gotten one of those vaccines. But what if you have not gotten that vaccine? And in India, as you know, most people have gotten either Covishield or Covaxin. Both Covishield and Covaxin are still not in the WHO list of, Covaxin is not in the WHO list of vaccines, which is considered certified by WHO, right? So I could face a problem if I have been vaccinated with Covaxin and I want to go to the EU states, and they would say, no, you have a vaccine passport certificate, but this is not acceptable to us because we do not yet consider Covaxin as one of the vaccines, which is something that we're comfortable with in terms of certificates. Now, Covishield also, as you know, in some countries, even though it's been a vaccine which has gotten WHO recognition, has not yet reached that list of vaccines which are allowable for vaccine passport programs. So what it then does is that you have this interesting set of dilemmas where you have managed to get a vaccine and you've gotten both your doses, but that does not necessarily allow you to be able to freely travel. So it impinges on your liberty till, of course, that vaccine reaches that list. So that's another issue that we need to talk about. And this is linked with the whole issue of vaccine nationalism, which I think we touched on in our previous discussion as well. And the lack of international standardization, that there is no one singular list that these are all the vaccines globally, and anyone, as long as they have had vaccines from this list, should be allowed to travel. Each country could have a different list, and that could impinge on your ability to travel. So I think that's where the fundamental issue is, that one, we don't have long-term effectiveness data yet, so we don't even know. As you know, there is this whole discussion around boosters. So even if you have 2 doses, what does that really mean? When did you get those your last dose? Should that be part of what you should be looking at if I am I'm someone who's looking at your vaccine passport, etc. So these are the kind of complications which will arise. So I think the real issue still remains the fact that there is vaccine access inequity, both globally and in our own country, for that matter, almost every other country which is a low and middle income country. So vaccine passport, on the face of it, seems like an interesting initiative, because it allows for people to demonstrate that they've been vaccinated, and for countries to be able to verify that. But of course, in the absence of everyone having access to a vaccine, it could still lead to a lot of people who could not be able to go and travel around because they were not able to access the vaccine. And this is lesser so a question of vaccine hesitancy and more of a question of vaccine access, in my opinion. Okay, I'll stop there. Thank you. You're muted, Abdul.
Thanks, Anand. As rightly said, several countries have introduced the vaccine passport when majority of the population in most of the countries haven't received the vaccine yet. Today, we have a new expert panelist, Dr. Aksa Sheikh. Dr. Aksa Sheikh is an associate professor of community medicine, nodal officer for COVID vaccination center, Hamdard Institute of Medical Sciences and Research. Dr. Aksa is one of the investigators in the clinical trial of Sputnik 5, an investigator in TransCare project and WHO Unity studies on COVID. Dr. Aksa is one of the editorial board members of the PLOS Global Public Health. We all know that it's the marginalized section of society that has suffered the worst during the pandemic in any country, including our country. Dr. Aksa has got extensive experience in working with marginalized sections of society in our country. Dr. Aksa will update us on her experience, enormous wealth of experience in working with various sections of society, especially during the pandemic. Dr. Aksa, welcome.
Thanks, Abdul Ghafoor, for this invitation and for the generous introduction. As you correctly mentioned, when we speak about the pandemic or the subsequent lockdowns, national lockdowns, state lockdowns, and the impact on the various populations and communities, there is no community or there is no population which has not been affected. So even if you are a highly privileged person, in some or other way, you have been affected by the pandemic. However, not everyone has been affected equally. So the marginalized communities have been disproportionately more affected by the pandemic as compared to the more privileged sections of the societies. Such marginalized sections could include women in our country. It could include children, persons with disabilities, people who are in the unorganized sector, people with mental illnesses, persons who belong to the transgender community, and so on. If you look at the overall, impact on the GDP, then we know that a few points of our GDP, have been slashed because of the 1.5 years of the impact of the pandemic on our economics. There has been a lot of loss of employment. The employment rate is now at 7%. At one point of time during the nationwide lockdown, it had touched 25%. And this is much higher, the current unemployment rate, as compared to the pre-COVID times. But what is interesting to understand is that it is not uniform. The loss of employment has been more amongst the women. When it comes to the recovery of the jobs, that is, people who had lost the jobs and have regained their jobs, that recovery has been poorer for the women. Also, we know that there has been a significant gender gap in the wage parity. The women are underpaid in our country, even in the non-pandemic times. And during pandemic, that has rather increased. In fact, also the amount of unpaid work and the caregiving that women do, especially with a lot of people now at homes, that work has also increased. Then when it comes to children, during the second wave, which was catastrophic, a lot of children have lost their parents. According to the data by the National Commission for Protection of Child Rights, nearly 3,600 children have been orphaned. They have lost both their parents during the pandemic. And this is official figure, as we always say. The real figure is likely to be higher. Nearly 26,000 children have lost at least a parent, and many of them have been abandoned. Nearly 300 children have been abandoned. We don't know what happened to their parents. And we saw on social media how, the messages for adoptions were floating, and then the government had to pitch in and say not to go for such illegal measures of adoption. So that's the amount of the problem. Domestic violence has increased a lot, especially when it comes to the violence against the married women. There have been increase in forced early marriages amongst child marriages amongst women. There has been an increase in the school dropout rates. And again, this has been more for the girls as compared to the boys. Because of the closure of the schools, we have lost a lot of numeracy skills and literacy skills amongst the children. There has been an impact on the mental health. Some studies which were done in Delhi showed that 1 out of 7 children are now having some kind of mental health issue. And this is not being addressed at all. There has been increase in the child labor because they can't afford online education. And very importantly, there has been nutritional losses because children who are going to Anganwadis below 6 years of age were getting some form of supplementary nutrition. Children who were going to the schools were getting midday meals. Though now the midday meal is replaced by the take-home ration by the government order, it's not reaching everyone. The report by Oxfam says that 35% of children, which is like 1/3 of the children, have not received their midday meals in spite of the government orders to that effect. UNICEF predicts that there has been nearly 10 to 20% increase in the under 5 malnutrition rate amongst the children. Another study, which is by Population Foundation of India, says that when it comes to the number of antenatal care visits for the pregnant women, there has been a 1/4 decrease in the number of antenatal care visits. And we never studied the impact of COVID on fetal well-being, on maternal well-being. And it was very late that we started vaccinating pregnant women and lactating mothers. Meanwhile, it's estimated that 10% increase in the stillbirth rate has happened during the pandemic, and nearly 18% increase in the maternal mortality rate. Also, when it comes to vaccination, as Anant was mentioning, there is a national level of shortage of vaccine. But again, India is a very diverse country. If you are in Delhi, probably you may not have as much shortage of vaccine as you are in a village at the border of Delhi and Noida. And again, there is a gender gap in vaccination. We knew that the women's had more vaccine hesitancy, had lesser access to vaccine. Those who were pregnant or breastfeeding were not given the vaccines initially. And that gender gap is also because of the financial assets being less, digital divide being more for the women. And also there's a rural-urban gap because the vaccination is happening through the COVID app, and there's also a digital divide which is there. When it comes to the persons with disabilities, they faced immense problem in accessing basic services like rations or pensions. There was a lot of neglect and abuse, including domestic violence from their families and caregivers. And very importantly, the access to the information for those who have visual impairment, hearing impairment, or intellectual disabilities was also there, because we had a very nationalized way of communication of vaccines, which was only in Hindi and English, and with no sign language interpretation for so on. When it comes to the transgender community, which is one of the most marginalized communities, and I identify as a trans person, a lot of trans persons have been involved in traditional professions like begging, giving badhai or ashirwad, or dancing in the dancing on certain social occasions, or even sex work. And all of these professions were affected, were literally curtailed during the pandemic times. And therefore they had, even those, I always say that when people don't have a job, they go for begging. But someone who's involved in begging, what will they do, when even that is taken away from them? And when it comes to the support from the government through National Institute of Social Defense, a policy was announced of 1,500 rupees one-time benefit being given to trans persons, which didn't reach even 1% of the official trans population in our country, which is roughly 5 lakhs. And also when it comes to vaccination amongst the trans persons, we don't have a data. In the last Lok Sabha session, the government said that they don't have data on vaccination amongst the trans persons. But if we consider that the others category in COVID app are the trans persons, then they are roughly 1/4 less vaccinated as compared to the cisgender population. And there are numerous issues like COVID app and financial issues and so on. So what the take-home message is that, when pandemic happens or when the lockdowns are forced upon people, the impact is disproportionately always higher amongst the more marginalized communities. And how much will be the impact depends upon the decisions which are taken by the governments, which are decisions which are taken by the powers, in our country. And it's very important to learn these lessons so that next time when we take decisions in future, the impact is lesser on the marginalized communities. That's all from my side.
Thank you, Dr. Aksa. The data that you presented is a real eye-opener to most members of this audience, including myself. As an infectious disease physician, I know how bad the COVID virus is on individual human beings. But much more than this virus has destroyed the social structure, affected every section of society, especially the marginalized section of the society. So we need to have a broader perspective. It's not a disease, that is not an infection that kills the individual, it kills the society. And we need to view this pandemic from a socio-economic and political perspective. Thanks a lot. We'll discuss all these aspects during our panel discussion. Now, let's start our panel discussion. We will discuss first on what Dr. David Heyman discussed on the equity and inequitable distribution of vaccine around the world. I will ask Dr. Jacob John's opinion on what Dr. Heyman explained. What is your opinion on the inequitable distribution? Why have we reached this scenario of inequitable distribution when we are facing a common enemy? That's the virus. We are not united at all. And why we, the humanity, reached this scenario of a fragmented manner of facing a common enemy?
Who are you addressing, David or me?
You, sir.
Oh, okay. Watching this pandemic from beginning till now is like watching a horror science fiction movie. One of the silver linings is the fact that vaccines were produced rapidly. Imagine that vaccines had taken the usual life of its own, like in the past. So we have done, science has done quite well. But we have not been smart enough to make it even faster or encourage production of vaccines in larger amounts. UK is a very, Public Health England had invested heavily in vaccines even in the month of March 2020. Public funded task force was established. And the result was that it is the first country to roll out vaccination in December 2020. At the other extreme, I'm talking about vaccine manufacturing or countries with expertise to make vaccine. The other extreme is India, which didn't do anything in terms of vaccine, particularly from the government side. Two private companies started doing some work. And even I know, for example, I've been discussing this problem with the co-vaccine manufacturers. There have been a lot of hiccups and delays in getting various stages of vaccine development progress through, because we have made rules. Those rules were to protect people from the profit-motivated companies taking advantage of gullible people. That is, they are good. But in this pandemic time, we had to ask very carefully, is Sabbath for man or is man for Sabbath? Are rules for the best interest of human beings, or what in the best interest of human beings makes you cut rules down a little bit? So the moment laboratory evidence and preclinical evidence of protection was available for vaccines, the issue was one of safety. So we should have learned to think differently during the pandemic time, to make use of the vaccines that the scientists were producing on a fast speed, but that we unfortunately did not cash in on. So, however, the vaccine shortage is real for the time being. And what is the solution? Each country would like its population best protected. Is that vaccine nationalism? Is that good or bad? I think we have to live through these times of uncertainties and inequities and try to do the best. To vaccine manufacturers have to scale up. Of course, vaccine prices have not been a big problem, because by and large, governments subsidized these vaccines, or governments purchased and gave the vaccine free or at marginal cost. So that's on the one side, vaccine hesitancy on the other side. In the US, vaccine hesitancy is a big problem. In most other societies, it's not a big problem. So this is the real world. We are watching a movie. We are in it. We are the actors. We are the players. We are also the watchers. So, so there is no answer to your question. I also feel very frustrated about this whole issue of the shortage of vaccine, in contrast to the enormous need and potential of the vaccine, both to save lives from COVID and save lives from the effect, socioeconomic effect of COVID. Back to you, Abdul.
Thanks, sir. Dr. Aksa, the same topic. The WHO COVAX facility hasn't yet succeeded enough in ensuring the equitable distribution of vaccine. What did go wrong? Is it because WHO is not powerful enough to control the rich and powerful countries?
You have actually answered the question yourself. You know, right from the start of the pandemic, the role of WHO has been doubted by all the economic superpowers. And it has been claimed that WHO has been siding with China in hiding the pandemic first, hiding and not finding out the data about the how the pandemic started. And now when it comes to the facilities, the COVAX facility depends upon the good gestures and the goodwills of the countries. And one of those important countries, of course, is India. India started with its vaccine Maitri program. You know, we started giving out a lot of vaccines to other countries, smaller countries, to develop diplomatic relationships and to build our diplomatic power around the Indian Ocean. But then there was soon a lot of political pressure on India to first serve its own citizens. And therefore, we saw that how the pressure was built on Serum Institute of India so to prioritize the stocks for Indian market rather than for the European Union. And there were also legal actions that were taken on Serum Institute for delaying on their commitments to supplying vaccines to the EU. So remember that WHO is not a body which produces vaccine. It is also not a body which has got punitive powers to control the pandemic. And though WHO has been wanting that by August 10, we should be able to get 10% of all the populations get at least one shot, that's definitely a distant dream. Mainly because there has been no, increase in the production of the vaccines, especially in countries like India, which are the major contributors to the COVAX facility. And secondly, because all the countries want to serve their own citizens first, rather than the poor African countries.
Thank you, Aksa. Dr. Bond, why do you think the countries are so selfish? Why do you think the rich countries are so selfish in vaccinating their own population first? Don't you think we are all global citizens, Homo sapiens, and we should distribute the vaccines equally?
Yeah, well, in an ideal world, yes. But I think quite honestly, the way it works is that, everyone probably is trying to drive political mileage as well. So policymakers probably want to be seen as doing something for their own country. So, they will hence make deals directly with the manufacturers, try to get as many doses. And we, of course, know that many countries had, in some cases, multiple doses per citizen available. So they're booked up to 4 or 5 doses per citizen, when there were other countries where even the frontline health workers had not even started to get vaccinated. So that is what is troubling, I think, is the fact that we have still a world order where, as long as you have the economic power, you can go ahead and make these kinds of deals. And there is little anyone else can do, including multilateral agencies like WHO, and except for making appeals. So, you have these repeated appeals from the DG as well, from WHO's, appealing to people's morality, to the fact that, all of us have an obligation to help each other. But beyond nice pronouncements, it is not really causing a lot of change, right? The fact that we have to depend on the generosity of richer countries also tells us something about the need for countries like us to work together, which is the global south. So I think India is in a good place because we have vaccine manufacturing capacity. South Africa has, Brazil has, Thailand has, some of the other global south countries have it. So I guess it's also a lesson for all of us to continue to ensure that we have our own capacity and we work with each other, because to try to think that in the kind of a global order we have right now, you could totally rely on generosity is not going to fly. The second issue is, this is also true of our own countries. I mean, even in India, we have the same rule, right? Yes, you need to have some form of identity to get a vaccine, either an Aadhaar card, maybe other kind of cards. But there are people who don't have these in our country as well. And they are perhaps not being able to access the vaccine in this, this is an issue which AXA has raised as well, that there will be segments of our population, there might be undocumented migrants also in India, who don't have access to vaccines. But this is a public health intervention, right? This is not a matter of choice. The more people we manage to get vaccinated, the better protection all of us as communities will have. And that is true across borders, that is true within our border as well. So what do we then need to do to make it an enabling ecosystem where we reduce an entry barrier to getting vaccinated and we ensure that there is adequate supply? As again, Professor John said, in many of our contexts, I don't think hesitancy is now such a major issue. Of course, misinformation is still a concern. There is a lot of misinformation still about the pandemic, and some of that can rub on to the concerns around vaccines as well. But largely now, you have huge lines in many parts of rural India. I stay in Madhya Pradesh. There have been stampede-like situations at vaccination centers, 300, 400, 500 people wanting to get vaccinated on a particular day and not even 50 doses being available. So that tells us something that, even that we need to figure our supply chains. We need to ensure that there is a clarity around when, how much supply is going to be available. And then we figure out ways to try to ensure that the part of a population which is not yet vaccinated remains protected. But vaccines are only going to do so much. Now, there is also this concern that even if you get a vaccine, you still, of course, need to keep ensuring that mask usage is kept up. You need to ensure that people follow public health principles like distancing, etc. But that is all flying through the window, right? If you go to any market, if you go to any gathering, the likelihood that people are following masking, for example, is going lower and lower. And that is something which should worry us because, of course, vaccines do offer you protection, but that doesn't mean that you are protected in any way. I mean, I had this funny experience myself where I'd gone to a supermarket and I had an argument with a couple of people who were not wearing masks, and I had to shout because they were just absolutely not willing to listen. And the standard response is, well, I've gotten both doses of the vaccine. Why do I need to wear a mask? So that tells you already that there is this whole issue of either a lack of understanding or perhaps just this feeling that we've gone through the worst and now we are all good. So while Professor John does, heartily, it's good to hear from him that maybe there will not be a third wave, but that doesn't mean that we are not yet, we're totally not susceptible as well, right? So I think that public communication, the need for reinforcement remains important. And hopefully part of that is all of us learning from this. This is not going to be the last pandemic. Let's make sure that we have the R&D capacity, the manufacturing capacity in the global south, so that we are less reliant on these global inequities, which go much beyond vaccines and healthcare. These are historical imbalances, which will take a long time to be addressed. So,
yeah, thanks, Anand. David, several virologists predict that if you don't vaccinate the population in poor countries, dangerous variant virus will emerge out of these countries and hit back the rich countries. You are a very influential person in the policy making process in your country. What do you think? And you belong to a rich country. What do you belong? What is your opinion about this thought process?
Thanks, Abdul. I really appreciated hearing the other panel members. It's extremely interesting to hear the different points of view. In fact, the need is to make vaccination a health security issue, because that's the only thing that speaks to the politicians in the North. Protect our countries. And so there hasn't been, in my view, enough emphasis on making vaccines not only a humanitarian issue, which they are, because in a globalized world, we should all be sharing vaccines, but also a security issue. Because as you say, Abdul, as the virus replicates, it mutates. And the more opportunities it has to replicate, because there's not the population immunity that we would like to see, the more opportunities there are for mutations. Now, India has a good population immunity. Jacob's shown us that. And India might not be a country that will be spinning off mutants, although we don't know, it's a random event. But what's clear is that countries that don't have vaccination and have increased transmission of the virus are a risk for developing mutants. So the way to really address this, in my view, is to make this a security issue in the North and make them understand, because they don't understand humanitarian issues very well, but they do understand security. And so make it a security issue so that they know they must share vaccines throughout the world. There's also, Abdul, some very interesting research going on right now on fragmentation of doses of vaccine, looking to see whether or not a smaller titer in that vaccine will in fact cause the same level of antibody and hopefully immunity. And that's going on in many countries around the world, trying to collect the evidence that will show that we can spare vaccines, as we do for a polio inactivated vaccine, as we do for yellow fever vaccines at times of emergencies, and as we do for rabies vaccines. So hopefully that research will solve part of the problem, making more vaccines available. But still, this understanding in industrialized countries is not, it just doesn't come by saying it's a humanitarian issue. But if you link it to security, it may be that that will be the key to get governments to really invest in COVAX facility. And all governments have a right to purchase through the COVAX facility. And if they were doing that, they could help drive the price down, because there would be mass vaccination, mass procurement of vaccines, and there would be less competition among countries. But as Jacob says, and countries want to give vaccines for the diplomatic, I think Dr. Aksa said it also, for the diplomatic benefit that they get from giving vaccines bilaterally. Very complicated issue, but I think all the points were well brought out by all the different panel members. So thanks, Abdul.
Thanks, David, for your excellent suggestions to the policymakers. And this is a time probably individuals like you should be sitting in the WHO, but you have been WHO a long time ago, and that is we are the roots now that you are not in the WHO in the decision making body at the top level. Anand, Dr. Aksa explained on the challenges the marginalized sections of the society faced during the pandemic. And you are also an individual involved in the bioethics and similar issues. What is your suggestion to the policymakers? Your suggestion and Aksa's suggestion to the policymakers to reduce such imbalance?
Yeah, so I think the first thing with any kind of advocacy you need to do with policymakers is to generating the right evidence, right? And Aksa, I think, has done an excellent summary, and I saw some of the audience comments appreciating that as well, of already what we know about the impact of the pandemic, especially on our more vulnerable sections of the populations, the marginalized sections of our population. But we really need more tabulation of data. I think one of the weaker points of our pandemic response has been effective data collection, analysis, and reporting around even understanding, for that matter, clinical and public health manifestations of the disease and doing it in a timely manner. So I think efforts need to be done. Of course, these should be done by the government, but also not-for-profits. There should be academia. All of us have a moral obligation to try to understand the impact of the pandemic on the various sections of society. And once we have that data, then we should be putting it out there, because that clearly tells both policymakers as well as the public that it had an adverse impact on multiple sectors of our economy, but also multiple sectors of our own population. And this is the kind of impact that we are seeing. Once you see that and once you demonstrate that, then I think it is for us to also advocate and say, now that we know, and this is clearly backed up by data, this is not conjecture of any kind, what is it that needs to be done to respond to these acute care needs which have been identified? How do we make our systems to be more resilient? How do we learn from this experience so that the next time there is ever a situation like this where you are going to announce an extended, stringent lockdown, that we prepare better so that those who are probably most at risk are supported? So if you're going to put in mechanisms where people cannot access food, where they don't have a way of earning their daily bread, they cannot, if they are daily wage earners, they lose their jobs, etc. And then you are expecting them to not go out or not to migrate, etc., not put them in high risk situations, then of course you need to put in social safety nets. And if you're not doing it, then of course we are violating their rights, right? And that is also true of anyone you want to put in isolation, quarantine. If you want people to give up their privacy for a public health need, then all of that, of course, requires the state to be reciprocally also offering them protection and supporting them. And if it has not managed to do it, then that tells us that there are serious issues or shortages with our safety nets as they exist, and these need to be changed. So I think there is a lot of learning which and documentation which needs to be done. Some of us are trying in smaller ways. Aksa and I, for example, are collaborating on a research project looking at the impact of the pandemic on transgender communities. But there are multiple other projects like this which are happening, and hopefully the data that comes out will be out there and show very clearly the impact of the pandemic on many of our sections of the population. And it is for all of us to then take that data and advocate with our policymakers to ensure that there is a response to the needs of these sections of our country, as well as planning better for the next time when there is a public health crisis like this. So,
thanks, Anand. Dr. Aksa, what is your suggestion or advice to the government? How can we reduce this inequality among various sections of society, at least from a pandemic perspective? I know the topic is too complicated.
Yeah, it's a very vital question, and especially, I'm seeing that a lot of audience is asking, what about the third dose? What about the booster dose? And that in fact shows the amount of privilege, that a lot of people who are asking this question have probably already got both their doses. And now they're worried about the third dose, while 50% of the eligible population in India has not yet managed to receive one dose also. And as we say this, probably by the end of this month or next month, once the probably Covaxin will become a vaccine for children or also available for children, the eligible population is also going to increase to a greater extent. Specifically with the demand of opening of the schools by the parents and giving vaccines to the children. So then that number of what we have achieved currently of around 47% receiving one dose would become even less, because the denominator of eligible population is going to increase. One very important insight which I got as a nodal officer of a COVID vaccination center, and it's been 8 months of working with the vaccination center, is that we are depending too much on the COVID app. And while it has a lot of its advantages of creating such a huge digital backbone, but also that we are tying down ourselves with the rules, as Dr. Jacob John was saying. So we shouldn't be so dependent on the COVID app that we can't vaccinate people without the COVID app. And trust me, even today, after 8 months of having developed and started that app, there are many issues for which we have no solution. There are certain days for which the data is completely wiped off and we have no data available for people who have been vaccinated on those days. Similarly, when it comes to the vaccination of the marginalized communities, you have to go out and reach to them, rather than expecting that the vaccination will happen at the ivory towers and people will somehow manage to get into those ivory towers and get vaccinated. As Anand mentioned, there have been even stampedes for vaccinations, but when it comes to the persons with disabilities, persons with intellectual disabilities, homebound persons, trans communities, we need to actually go to them to give vaccination. Otherwise, the number will increase, but it will increase amongst the privileged sections of the societies, and will create these populations and subpopulations and communities who are not vaccinated at all. We saw that during the polio vaccination drive also, that certain pockets, for example, in Muzaffarnagar, were completely unvaccinated. We never addressed the vaccine hesitancy to start with. It was only later that the community and the social mobilization had to be done to wipe off polio. We see the same problem now with polio, in Pakistan and Afghanistan, where there are pockets, and it's been years we have been trying, but we have not been able to get them, free from polio. Another very important thing when it comes is about information about vaccine. There is vaccine eagerness, but there's also a misinfodemic which is happening. Just to give one example, even today, only 1/3 of the nurses in my hospital are vaccinated. 2/3 are not vaccinated because they're worried that it has impact on their fertility. They are worried that, they're thinking that they've already got antibodies in the body, so they don't have to get vaccinated. And they'll wait till there is concrete data that it does not cause infertility, that it is safe in pregnancy, and so on. Similarly, amongst the Muslim communities, there has been, a misinformation that probably there's something in the vaccine to decrease our population, and therefore they have not been getting vaccinated. And therefore we need the strategic and focused information campaigns for specific communities, for specific misinformations. Only then it is possible. One nation, one message is not going to serve that purpose.
Thank you. Very, very valid message. Dr. Jacob John, does that herd immunity concept valid during an era of variants? Are we still having a herd immunity target in various countries? Or is it valid when we have variants emerging out with higher R naughts or R?
Herd immunity is a tool in the hands of epidemiologists. Because the jargon of experts became public knowledge through media, people have been using these words rather glibly. R0, R, herd immunity threshold. So herd immunity, I will come back to herd immunity in a minute, but let me say one very, very important point. We use herd immunity to understand the epidemiology. The language of herd immunity came from veterinary science, from herds of cattle. They are a cattle herd is in a confined space, no in-migration, no out-migration, and additions are only through birth within the herd. Of course, human communities are not herds. The translation of herd immunity to human societies came only through vaccinologists. If you use the herd immunity calculations, you could predict what proportion of the susceptible children or people have to be vaccinated to control the disease to a large extent. So that is how the herd immunity became popular jargon among pediatricians and in vaccinologists. When the pandemic came, the new experts projected, some great epidemiologists, even in Edinburgh, projected that once the infection reaches to a certain proportion of people, and it was predicted that between 60 and 75%, let's take 75% of people, we would have reached herd immunity and the virus would disappear from the world. That is the kind of misreading, misunderstanding of the concept of herd immunity. So herd immunity is not going to help us understand the epidemiology because herd immunity is something that we apply for vaccination. However, we do know that herd immunity principle determines the size and duration of an epidemic or epidemic wave. Okay, let me clarify one more thing, that what I predicted was the unlikelihood of a third wave. Please do not understand that that somehow solves our problem. We are getting 40,000 cases every day. In 100 days, it becomes 4 million. A wave would probably create a 4 million infection in a matter of 4 weeks, whereas we are now talking about that spread out over 3 months. So the problem is very much with us. Senior citizens, those with comorbidities, will have the same risk of severe disease, need for hospitalization, need for extra care, and death. So the absence of a wave only releases the fear and tension from the minds of a lot of people. But the problem of the epidemic is still with us. And as David and everyone has said clearly, the lasting solution is vaccine. The science of vaccine went far ahead in its pace than the administrative thinking of getting the vaccine manufactured in sufficient amounts and being made available to people. Today, the problem is not that rich countries are hoarding vaccine. They're also using vaccines that are available to them. They were smart enough to make advance purchase and payments and all that. So they had early access to vaccine. There is not just enough vaccines to go around. Are there ways of getting more bang for the buck? Tamil Nadu and Kerala are eking out 12 doses out of a 10-dose vial, 6 doses out of a 5-dose vial, 0 wastage. So that is one way. We could think in terms of intradermal inoculation so that you have a dose sparing schedule. However, Vaccine manufacturers are not going to do that. Why? Because they do ultimately want their profit for the next vaccine. So this is a public health approach. Unless the ICMR in India or the Ministry of Health experiments with intradermal vaccine as a dose pairing, you can have one dose can be divided into 5 doses. So for 10 doses, you have 100 people or 50 people vaccinated. All those are just interim short-term solutions. We just have to invest more money in vaccine manufacture and create more vaccines. So that's just to clarify the issue of no third wave doesn't mean that the problem is solved. The vaccine issues are there. So back to herd immunity. Herd immunity is a nice concept, but please don't trivialize herd immunity by people using it to somehow explain away things or put reliance on herd immunity, saying that our problem will be solved by herd immunity. Okay, herd immunity is a natural process. Particularly when vaccine is available, we can predict that if 65 to 70% of people are vaccinated, then we could control the infection. And if you can top it up by another 10%, we can eliminate the infection. And if you can top it up a little more, you can eradicate the infection. And these are potentially available. So herd immunity helps you to make these calculations. But calculations are not keeping up with the vaccine manufacturer. Thank you.
Thank you, sir. So Dr. John has clarified his statement. He has stated there will not be a third wave, but the problem is still out there. The number of cases will be probably evenly distributed over a prolonged period. So there's no reason for us to be complacent. We need to speed up our vaccination. All COVID appropriate behavior must be continued the same or in a better fashion. Thank you, sir. Now, let me ask a doubt to Dr. David Heinemann. The World Health Organization is investigating into the origin of the pandemic. Let the WHO continue the investigation, but several experts have raised the possibility that the virus could be a product of gain of function research. Could be. Now, let's only assuming a possibility. Now, even if it's a possibility, the discussion has come up. Don't the world has a responsibility to avoid such possibilities in future by regulating the gain of function research?
It's a very good question. And you know, gain of function research really first came to the public's attention when the Netherlands, a laboratory in the Netherlands and another laboratory in the US were able to gain function on the influenza virus and actually make it transmit more easily in animal models. And so since then, there's been discussions about really how to move forward with this gain of function research, because some of it could be very useful. At the same time, it's very dangerous, especially if an organism escapes from the laboratory. So what needs to be done is the academies of medicine of the world, or some group within WHO possibly, sit down with scientists who do the research themselves and develop what they believe is an ethical framework around this. We can't stop progress by stopping research. I'm not saying that gain of function research is necessary, but we don't know yet what the true value of it will be. And until then, we need to make sure that if it is done, it's done in the proper way in proper laboratories. So we need to be sure that there are standards for laboratories that are followed by countries, and that there are also standards for ethical research. But even if they are developed globally, it still is a false security, because it's up to countries to enforce those regulations, those requirements. And it's also up to countries to stop rogue researchers, those researchers who want to do research to cause harm, from doing the research themselves. So it's a very complicated issue, but it demands scientists working together to develop that framework of ethics and also security around the research. Does that answer your question, Abdul?
Yeah, I just want to clarify. We have a nuclear non-proliferation treaty. Can United Nations formulate such a treaty so that it's compulsory for all the countries who are signed up to the treaty to follow the guidelines or even the regulations?
Actually, there is the Biological Weapons Convention, which is the treaty on development of biological weapons. That treaty requires of countries no research on biological weapons. That protocol, there was a protocol developed to do inspections in countries to make sure that those countries that signed the convention were not doing that research, but that was not accepted by the countries. And so we have a weapons convention which says that countries will not do research that could modify organisms in such a way that they transmit more easily or cause more serious illness, but there's no way of enforcing it globally. Each country must enforce it itself, and hopefully that's what's happening. Although we learned in that Biological Weapons Convention discussion that no country would give up its sovereignty to allow other countries to come in and inspect their facilities. Yet we're expecting that today, that countries where there are organisms that are spreading around the world will open up and let investigators come in and do research in that or find out what's going on in those countries. So it's a real difficult issue, national sovereignty and the willingness of countries to allow teams to come in and work with them.
Thanks, David. Dr. Anand, David mentioned a very important point. We have a biological weapons convention, but that's regarding the weapons. What if countries say we are not developing weapons, we are doing gain of function research to develop drugs, vaccines, therapeutics, and diagnosis, and not for weapons, just like some countries claim, for our nuclear research is only for peaceful purpose and not for weapons. The same can be translated to the viruses as well. How can we overcome this particular situation?
Yeah, I guess, of course, there is a need for regulation in science. We need to promote science, but we also recognize that good quality governance and regulation is important. That operates both, of course, within the nation and internationally, because there are certain red lines in science, and those red lines might change over time as our understanding of science changes. But we need to be also careful because of the potential of misuse. And that is true of nuclear weapons, but it is also true of biology and the way we do biology, right? And the way we do research. Now, that definition and that clarity, of course, requires us to come up with those clear pronouncements around what are those red lines and how are we preventing scientists, or for that matter, any country from crossing that line, and what is the enforcement mechanism. If you don't have transparency, if you don't have enforcement mechanisms, then you will have excellent guidelines written. You will have a lot of very interesting meetings happening in Geneva or in New York, in the August gatherings, but you can't really figure out if people are violating that. So that remains an issue, I guess, in global governance. How do we make this something which is enforceable? And also, how do you convince scientists as well as countries that these red lines exist for a good reason and these should not be crossed? Because quite honestly, there is going to be no situation where any country can protect itself from the potential possibility of a negative connotation because of doing something, right? If any country feels that they are going to do this and yet remain protected and only other countries will be impacted, it's not going to happen. It could end up biting you as well. So I think for each country also, I think they should be cognizant of this and ensure, because at the end of the day, all of us want to promote science. We want more science to happen. We want to use science as a public good, as a way of better human advancement, but that should not happen on the back of research which is unacceptable, unethical, or done in a way that it could be causing danger to our communities and our populations. Thank you.
Thanks, Anand. Aksha, what's your opinion about this aspect of gain of function research and the need for regulation?
I think, while we are discussing at preemptive measures of preventing such future mishaps, we must also look at what can we do in case the current pandemic is a result of that. So there has to be a talk of reparations, of someone compensating for the losses. And it's not just the economic loss, millions of people have lost their lives. They cannot be brought back. But then there has been also erosions of GDP, and that affects human lives. So we also need to talk about how a fair probe can be done, which is not politicized, and also how the reparations or compensations, if at all needed, can be gained. And I think both of them have very well discussed that there has to be a balance between pursuing our scientific aspirations and also ensuring protections. But in the current global order, I see that difficult. I mean, call it my pessimism, but then we've just seen what has happened in one country where one superpower left without any responsibility, and then the consequences. The same also applies for biological warfare.
Thank you, Aksha. Very important points Aksha has made. We should not politicize any investigation in the origin of the virus, and then the science should progress. So we need a balance between the research on gain of function and then preventing the misuse of gain of function research. Dr. John, what's your expert opinion on the gain of function research and preventing any proper any future misuse of the gain of function research?
I totally agree with you in terms of the need for strict regulation, at least in the regulatory language. Now, research by a scientist happens in an institute, and the institute has to find funding for that research. So there are funding agencies involved in research. And of course, there are national regulatory agencies. So research is not a private journey. It is a matrix of many people involved, and the regulation to prevent gain of function research is a minimum requirement that we need. How it is applied, how we can apply it, etc., will follow. In the United States, for example, during the previous Democratic president, gain of function research was banned, was disallowed. Whereas there is this accusation that US funds were used in China to continue work on gain of function research. So if there was an international regulation, that would not have happened. So I think we have to think through this without handicapping scientists for loss of function research, for attenuating viruses to make vaccines, etc. At the same time, manipulating the genes of microbes to make them more infectious or more virulent. I think we need to face that issue squarely, think through, and make sure that all right-thinking scientific leaders are against that approach of research to create pathogens with greater virulence and greater infectiousness. That, of course, is the background of bioweapons. So we need to think through this very clearly, and we need to regulate in such a way that funding agencies cannot fund such research, and institutions will not do such research, and therefore we need to strictly, at least the beginning is to think through, articulate, and make regulation. How to implement it is something different from creating the regulatory language. So I'm with you. We need to to think through this very, very clearly, very fast and comprehensively. I think WHO and various nations, national regulatory agencies, funding agencies will have to come on board and join this movement of disallowing gain of function research to make pathogens more virulent or more infectious. Whether it is for weapon or for research, the same thing. It should be banned.
Thank you, sir. We had a very long discussion, more than 1.5 hours. When we initiate, when at the beginning of the meeting, we had around 150 participants, and even now we have more than 80 participants after 1.5 hours. We discussed about the third wave, the variant, the ethics of vaccine passport, immunity passport, the impact on marginalized community. So we discussed almost every aspect of the COVID pandemic situation in a very, very interesting and we had a range of the senior most individuals and experts in the field. Thanks a lot for the panelists and thanks a lot for GCSMC for organizing this meeting. May I invite Dr. Mahesh to take over.
Hi. Thank you, Abdul. It was a very absorbing evening of discussion, and on behalf of Wipro and GCCMC, I thank the panelists. Wide variety of issues were discussed, and I'm sure all those who attended it, I saw some comments coming up, and everyone seems to have enjoyed this. It has thrown open a lot of questions. Some have answered, I would say not 100%. It has opened up some more thought process in various people's mind, because it has been a very probing discussion, I would say. A lot of facts brought out, lot of aspects covered, and it has made, I'm sure, all those who have sat through the full thing, to think whether the policies on various vaccine issues, on variants, on who's getting it, social issues, and it has been a very absorbing evening, at least for me, and I'm sure everyone all enjoyed it. I thank once again Dr. Raksa, Dr. David, Dr. Anand, Dr. John, and Dr. Kapoor for this lovely discussion. Thank you very much.
Thanks a lot, everybody. Thanks a lot for participating in the meeting. And the attendees, thanks a lot for participating in the meeting. It's our pleasure.
Good night.
Good night, everyone.
Good night. Thanks, David.